So I'm Dawn Landon, a CHAP Education and Outreach Coordinator. I'll be a moderator for today's webinar. And today's presenter is Dr. Christopher Scott. Christopher Scott grew up in Alaska and has completed his undergraduate education at Stanford University, graduating in 2006 with a degree in International Relations with honors. He then served in the Marine Corps for 8 years as a direct air support control officer and artillery officer, first completing deployment to Iraq and then one as a member of Marine Expeditionary Unit. His second deployment includes several months in Pakistan to assist with flood relief efforts. While preparing to attend dental school, he completed his dental prerequisites at Oregon State University or on an Indian Health Service pre-dental scholarship. He also volunteered at the San Diego American Indian Health Center Dental Clinic and the Alaska Native Medical Center in Anchorage, Alaska. After leaving active duty, he obtained his doctorate in dental medicine at Harvard School of Dental Medicine, graduating in 2018. While a dental student, he volunteered to provide free dental care at the Wampanoag tribe of Martha's Vineyard and established an elective rotation at the Alaska Native Medical Center for Harvard dental students. He then trained in oral and maxillofacial surgery at the University of Tennessee Medical Center in Knoxville, Tennessee, from 2018 to 2024, during which time he also completed a medical degree at the University of Tennessee Health and Science Center College of Medicine in Memphis, Tennessee. During his residency, he was trained by Dr. Eric Carlson, one of the leading experts in the world on oral cancer. He is currently completing a fellowship at the University of Oklahoma in cleft and craniofacial surgery. After graduation in June of 2025, he will be moving to Vermont with his wife Natalie and his sons Tatum and Griffin to join a private group practice and provide cleft and cranial care at the University of Vermont's Children's Hospital. He is an enrolled member of the Cherokee Nation and the first enrolled member of any tribe to be trained as a cleft and cranial surgeon. So I welcome you, Dr. Christopher Scott, and Dr. Scott, the floor is yours.
All right, thank you very much for that introduction, and yeah, we'll go ahead and get on with it. So let me go ahead and share my screen here. And so, like we previously mentioned, we're going to be talking about oral cancer. And here's an outline of the topics we're going to be discussing today. Briefly introduce the topic and define oral cancer, discuss a little bit about the epidemiology of oral cancer, discuss risk factors that can lead to oral cancer, talk about the physical exam recommendations for when you're screening for oral cancer, then talk about the diagnostic process. What does oral cancer look like? What does oral cancer, pre-malignant lesions look like? What are other conditions that can also resemble oral cancer that you may see in the mouth and need to be able to distinguish from oral cancer? And then once the diagnosis of oral cancer is made, how is it staged using the TNM staging system, which is the tumor, the nodes, and then the metastases. And then we'll also touch on prognosis and treatment for oral cancer. So a little bit of introduction. You already had a pretty extensive introduction, so I won't belabor those points. But as previously mentioned, I served in the Marine Corps after college. And in the Marine Corps, I found myself surrounded by a high-risk environment for oral cancer. Because if you look at the statistics compared to all the other branches of the Marine Corps, Marines have a tendency to smoke more, drink more, and engage in more high-risk sexual activity than any other branch. And then also once I went to residency at University of Tennessee Medical Center in Knoxville. Knoxville is in the middle of the Appalachian region. And one thing that is clear about Appalachia, and particularly Southern Appalachia, is it is a place that smokes a lot of cigarettes and uses a lot of other tobacco products, putting the residents there at high risk for oral cancer with a higher rate of oral cancer than other areas. And then also, I have the Mountain Dew logo there because Knoxville is where Mountain Dew was first developed. And Mountain Dew, not many people outside the region know, is actually a slang term for moonshine because Appalachia and the Appalachian Mountains around Tennessee are where a lot of moonshiners made the illegal alcohol, especially during Prohibition, and then even afterwards, they continued the tradition on of making alcohol illegally up in the mountains and avoiding authorities. And the Mountain Dew beverage also was originally made to help sweeten up and flavor that illegally made moonshine. So you'd pour your Mountain Dew into your moonshine and make it a little bit tastier. And as we'll see, alcohol use is also a significant risk factor for oral cancer development. So kind of comes as no surprise that Knoxville is an oral cancer nexus. And so provided a lot of clinical exposure during my residency to oral cancer and all the varieties of pre-malignant lesions. So next, we'll kind of go ahead and define what is oral cancer. So it's a cancer that forms in the tissues of the oral cavity or the oral pharynx. You can kind of see there in the top right of the screen, the oral pharynx is defined as the area that is kind of behind the oral cavity and then is superior to the epiglottis. Epiglottis kind of being the divider between the laryngopharynx and the oropharynx, and then it's the oropharynx superior border is defined by the soft palate. That's really the divider between the oropharynx and the nasopharynx. Both the oral cavity and the oropharynx are lined with squamous epithelium, and 90% of those cancers are squamous cell carcinomas, which makes sense because they arise from the squamous epithelium. So in this presentation, in the 45 minutes we have, we'll talk about really primarily squamous cell carcinoma. This is not to say there are not other cancers that can occur inside the oral cavity. Those include minor salivary gland cancers, all relatively rare. And I've listed the major subtypes there below. Also, lymphomas can occur inside the oral cavity, and then also mucosal melanomas. All of these, however, are comparatively rare in comparison to squamous cell carcinoma. So move on, talk a little bit about epidemiology. In the United States, there's about almost 60,000 cases that are diagnosed per year. This leads to over 12,000 deaths per year. It is a disease that predominantly affects men. They're at least double the risk compared to women. And this isn't necessarily due to any sort of intrinsic factors of being male. It's primarily due to lifestyle choices that men tend to make relative to women, and then also some public health interventions in the past have also been protective for women relative to men, although that's changed recently. And then I want to say usually we're used to cancer risk and mortality going down as public health interventions are able to take effect and also as treatments improve. However, with the oral cancer, the cancer mortality has been increasing 2% per year from 2009 to 2022. Overall, 1.2% of Americans will be diagnosed in their lifetimes, and 3.1% of cancer diagnoses in the US are oral or oropharyngeal cancers. Not common, but not rare, and especially depending on your region and your population you're looking at, can be fairly frequent. And then also, I wanted to have that graph in the top right. Talks a little bit about and showing like the instance of oral cancers per 100,000. And I especially like this one because it's one of the few that actually has any data for American Indians and Alaska Natives. And so the Native Americans are represented by that kind of orangish line on the graph. You can see it is overall, Native Americans have a lower risk than the average American. Risk is highest in white non-Hispanics and slightly lower in African Americans. And then I wanted to include that map, and that map shows oropharyngeal cancer incidence rates. And you can see there's a lot of variation across the United States. But as I kind of touched on, the Appalachian region and then the Deep South are the two areas most affected by this disease. And this does really tie into a lot of uh, social practices, lifestyle factors. Um, so we'll jump right in, talk about some risk factors. And one thing that is common for all these risk factors is that everybody knows that all of these lifestyle choices carry risks, but usually oral cancer is not the one people most commonly think of. So, for example, tobacco is the most important risk factor for oral cancer. However, if you stop the average person on the street, when they think of tobacco health risks, they primarily think of lung cancer. And so, but unlike lung cancer, almost all forms of tobacco use carry risk for oral cancer. So cigarette smoking carries risk, but so does pipe smoking, and so does cigar smoking, as does dipping, chewing, and snuff. So sometimes, yeah, you'll meet patients that are cigar smokers, and they often will prefer cigars because it doesn't involve breathing it into their lungs, and so they view it as safer. But then you'll see these very same patients, unfortunately, get diagnosed with oral cancer that is almost certainly attributable to their cigar smoking. And then I think everybody recognizes that dipping and chewing tobacco is also risk for developing oral cancer. But something that's new to the market is these smokeless tobacco pouches, marketed commonly as Zyn. That's a very popular brand name, and it was the FDA authorized marketing Zyn because it was deemed safer for use by adults who completely switched from other forms of tobacco. However, this does not mean it is safe. It is it's only safe in comparison to smoking or chewing tobacco. So young kids that are picking this up in high school, it is much less safe than uh, abstaining. And unfortunately, like the exact risk is not yet known because it's still a pretty new product to market, and we probably won't have data for a decade or two to really be able to reliably state what the risk is, you know, per dosage and over time of using products like Zen. Also wanted to throw this map up there, and that really underlines the fact that tobacco usage is just a huge risk factor for oral cancer development. You can see the map on the left is the map of smoking in the United States. Some areas have smoking rates of down at around 10%, and then some are upwards of 35 or 40%. And as kind of previously discussed, Appalachia and the Deep South are where most of the smoking happens. And you can see there on the right, that's the heat map for oral cancer mortality. So people that actually end up dying of this disease. And you can see all that red area is concentrated in the Deep South. Um, and so, I mean, yeah, like really like the oral cancer mortality and the smoking heat maps are almost the same. So even without consideration of other risk factors, tobacco smoking is a huge determinant in who gets oral cancer and dies from it and who doesn't. Another important risk factor is alcohol. Similar to cigarette smoking, alcohol is not thought of typically as its main risk being oral cancer. It's most people think of alcohol as causing risk of maybe liver disease or possibly deadly withdrawal symptoms such as like delirium tremens. But it's long understood to be a risk factor. Interestingly, in animal models, pure ethanol is not carcinogenic. However, the breakdown products are, such as acetaldehyde. Um, and this graph here shows really like how the risk of oral cancer development is related to alcohol use. Your risk goes up primarily with intensity. So the more you drink, the higher risk. It is not really related to the duration. So the top two graphs really talk about are showing intensity and how it relates to risk. And then the bottom graphs are related to how many years you've been drinking and how much your risk is. So there is some mild elevation of risk the longer you drink, the higher risk you're at, but it is not nearly as clear an association as it is for uh, how much you drink. And really like kind of those that once you hit five drinks or more, that's when your risk is highest. After that, it kind of plateaus. So um, drinking a six-pack versus drinking a fifth of whiskey every day doesn't seem to be that much increased risk for oral cancer. However, your liver risk is going to be liver disease risk is going to be much, much higher. There's also a multiplicative effect of tobacco and alcohol. So alcohol and tobacco together seem to carry more risk than you'd expect from given their individual risks. So those that drink and smoke are at much, much higher risk than those that drink or smoke alone. And Dr. Carlson, my chairman at Knoxville, who has extensive experience in head and neck cancer, always said like back, when he first started treating oral cancer, the waiting room was typically filled with old white men who drank and smoked their whole lives. And so I got a few photos to kind of show you the sort of typical patients we would think are going to become oral cancer patients. And so, Pete, down there on the bottom left, most interesting man in the world. In most of these ads, he's drinking Dos Equis and then smoking a cigar. And then you have Christopher Hitchens there in the top middle. Famously drank Johnny Walker and chain smoked and died of esophageal cancer at 62. And for those that aren't familiar, he was a famous essayist and polemicist with a lot of controversial opinions. Probably most famously served as devil's advocate during the evaluation for sainthood for Mother Teresa, in which he argued she was not a good person, and also wrote numerous other controversial but thought-provoking essays. And then top right is Humphrey Bogart, seen here in Casablanca, in which he pretty much smoked in every scene and drank in most of them. Also died in his 50s of esophageal cancer, likely related to his smoking and drinking. So these were the sort of patients as an oral cancer surgeon you pretty much expected to see: old white guys that smoke and drink. But more recently, there has been another risk factor. So Prior to the sexual revolution, oral sex was relatively rare outside, at least amongst heterosexuals. It was practiced primarily by married couples. After the 60s and 70s and the sexual revolution, um, it was liberated and became commonly practiced amongst unmarried couples. And oral sex has been and overall, when you look at the demographics of who practices it, tends to be concentrated more heavily in populations that are heterosexual, white, and also more educated. And so this is kind of in contrast to our the demographic we had previously expected. So you'll start seeing younger people. And since smoking is commonly associated with lower socioeconomic status, it is in contrast where you'll see people with higher socioeconomic status coming in with oral cancer as a result of changing sexual practices. So here is a study that viewed oral sex and demographic factors, and as well as exposure to HPV, because in this case, really the risk factor that is posed by oral sex is transmission of the human papillomavirus, and particularly several high-risk strains, of which HPV-16 there in that right column is one. And so I wanted to highlight a few boxes here. One being that males are at higher risk for oral HPV infection. And then odds ratio for those that have performed oral sex as of 2014 when the study was published. Highest incidence was amongst people in their 30s to 40s. More also common in people in their 20s. Very uncommon in people that are older, and particularly those that came of age before the sexual revolution. And you can see it's also most commonly it's most common within white populations. Unfortunately, there was no data available for any Native American or Native Alaskan populations. And then if you're college educated, it's more than twice as likely. And then also 3 times as likely if you're married. So overall, this leads to a patient population that looks very different than the old white men that were seen almost exclusively back in the 80s. So HPV infection is associated with a number of cancers to include cervical, vulvar, penile, as well as oropharyngeal. Pathogenesis is viral proteins E6 and E7 inactivate some of these tumor suppressor genes like P53 and RB, which leads to cell damage and accumulation of DNA damage that can eventually lead to cancer development. HPV 16 and 18, which are subtypes of the virus, are the most common high-risk subtypes, and as we'll later see, they're targeted by vaccines that have been developed. And so the top pictures are of, in contrast to these old white men that had been primarily seen in the past for oral cancer patients. These patients are younger, they're educated, and they don't look like the patients did before. So I want to make sure that's pointed out so that just because someone's young and has a high socioeconomic status does not mean that you can discount their risk of having oral cancer because they're exactly the population you would expect to be at risk for HPV. And I wanted to have this graph at the bottom that shows basically the risk of oropharyngeal cancer and as it relates to HPV. And really, I'll draw your attention to the HPV positive oropharyngeal cancer, which is the blue line there. And you can see that it is going up fast and is really what's driving the increased prevalence and diagnosis of oral cancer seen in the last 25 years. Fortunately, there have been vaccines developed. I'm not going to go through this too extensively, but when initially developed, it was only given to young girls because the risk was primarily thought of as being cervical cancer or vulvar cancer. And the thought was that also if you protect the girls, that the boys will essentially be protected. But this, of course, ignores the risk of heterosexual male couples who would not have any protection through this. And then it also ignores the risk of penile cancer and oral cancer in both sexes. So at least now we have several options for our vaccines, and all of them are approved for both girls and boys, except for Cervarix, that's only girls. But Gardasil and Gardasil 9 are both approved for boys. Unlike when first approved, it literally was not approved for use in males. So overall, it's very hopeful that in time, HPV-associated oral cancer is just going to go away as vaccination rates rise. But we do have a long way to go. There's a lot of people that are too old to have gotten the vaccine, and then we can see vaccine coverage varies widely by geography. Vaccination rates are also, low in the Deep South and Appalachia. They tend to be highest on the West Coast and the Northeast. And then also in kind of the Mountain West, particularly in states that have high Latter-day Saint populations, there's also kind of limited compliance with vaccination recommendations, likely due to religious beliefs. Marijuana. I grew up in a hippie town in Alaska, and marijuana was often viewed as a pretty benign drug. Most people viewed it as, something natural, and so they didn't think of it as very harmful. But marijuana has been known for a long time as being a risk factor, and it's not just the carcinogens present in marijuana smoke. It's actually something within the chemicals that actually is immunosuppressive. And so cannabinoids can promote the progression of HPV positive head and neck cancer because of a specific interaction with proteins associated with the immune system. And the it doesn't seem to be as much a risk factor on its own, but when combined with HPV infection, it can cause significantly elevated risk. And then bottom right there, that is a map of the legality of marijuana as it's becoming increasingly socially accepted. So blue states are states where they have recreational marijuana approved. Green states are states that have medicinal marijuana approved. And then the states that are in the gray have no legal marijuana. And so I think as legal marijuana has been, is around for longer, and there's increased associated use, we're going to see, or we'll be able to better define the actual risk presented by marijuana use. Now we're going to talk about physical exam and the importance of detection. So here are the 5-year survival rates for squamous cell carcinoma, which is essentially the same disease, but it just varies by location of the body. So if it's on the skin, most commonly occurs in sun-exposed areas that are visible outside of clothing. 5-year survival rate is 98%. Oropharyngeal, only 68%. So it's the same basic disease, but has a much worse prognosis in the oropharyngeal cavity because it's not in an area that is commonly seen. It's inside the mouth, and so unless you open wide and take a look in the mirror, or you have an oral health professional do a careful exam, it can be easily missed and can go undetected for months to years before it's ever seen and treated. And then you can see in that graph below, your 5-year survival is heavily dependent upon at what stage the disease is detected. Stage 1, really pretty good prognosis, especially if it's in the oral cavity rather than oral pharynx, looking at about almost 85% survival rate in 5 years. However, if it is an oropharyngeal cancer discovered at stage 4, only a 30% survival. Physical exam. Number one, start with an extraoral exam. And so this gentleman on the left is having his cervical lymph nodes palpated. So even in the case of a primary tumor that cannot be seen, such as back there in the oropharynx behind a tonsil, sometimes you can detect it after it has been after it's spread to a lymph node, and you can feel nodal disease through a firm, usually non-painful lymph node. Painful lymph nodes are more common in infections, so non-painful, more typically cancer. And then on the right there of the screen, this is an example of how to do a good exam and see all the areas of the mouth you need to see as an oral health professional when screening for oral cancer. And I think the big takeaway here is you got to move the tissue to get a good look. So pick up the upper lip, pick up the lower lip, and look at the insides of that. Get a tongue blade, depress the tongue to get a good look at the soft palate and the tonsils, and then make sure that patient touches the roof of their mouth with their tongue to look at the floor of mouth and the ventral surface of the tongue, and then get a piece of gauze so you can help retract the tongue and really get a good look at the lateral borders. So simply like doing an examination by having them open their mouth and looking around a little bit with the mirror is not sufficient. Going on into the diagnosis section of like what happens when you see something that looks like it shouldn't be there. And this is a position paper that is published by the American Association of Oral and Maxillofacial Surgeons. And the lead author is Eric Carlson, who is the chair at University of Tennessee, where I trained at. And so I've spent a lot of time with Dr. Carlson in his clinic, and I'm very familiar with his algorithm for diagnosis, treatment, and management of both pre-malignant lesions and oral cancer. And this is really, his approach has really been adopted by the AAOMS. So jumping right in. Leukoplakia, what is it? What does it mean? Leukoplakia is basically a basket term that can be used to describe anything that's a white plaque in the mouth, or really just any white plaque. But for our purposes, it's going to be something we're looking at in the mouth. About 1 to 3% of the population is going to have something that could be described as a leukoplakia. On average, people, if you see a leukoplakia, there's a 1% risk every year that it could be turned into cancer. Subtypes, if it's a really homogeneous looking white plaque, it's a relatively low risk, so somewhere below 1%. Non-homogeneous, so if it has a lot of like furrowing and creases in it, that's an elevated risk. And then verrucous, which is actually the appearance of this picture, that would be described as a verrucous because it kind of has a wart-like appearance with little projections. That's the highest risk. And this lesion, after biopsy, was identified as a verrucous carcinoma. Erythroplakia. It is a fiery red patch that cannot be characterized clinically or pathologically as any other definable disease. Basically just translates to a red plaque, even though it's really more of a patch. Prevalence, much less common than leukoplakia, depending on your population, generally under 1%, could be as low as 0.02%, or almost, or 0.83%. In this case, if it is not malignant, it is likely severe dysplasia or carcinoma in situ, and malignant transformation rate is high. Difficult to get an exact rate because it's sufficiently rare. and a sufficient number of these, once biopsies, are determined to be actual cancer. And then erythroleukoplakia. So this is a mixed red and white appearing plaque. It is extremely suspicious for malignancy. Prevalence is not clear because it's often reported as dysplasia or squamous cell carcinoma. And if it's not malignant at the time of biopsy, transformation rate is very high. And this erythroleukoplakia, when biopsied, was demonstrated to be invasive squamous cell carcinoma. There are a lot of other things, however, that are white plaques that can potentially look like oral cancer. So oral candidiasis, it is an infection of oral candida, a fungus. And one of the big ways to tell immediately that it is not cancer is that it can be wiped off. So if you take a piece of gauze, you can kind of wipe it off. Don't worry about it. It is that's oral candidiasis. Risk factors for development include immunocompromise, also denture wear, poor oral hygiene, and antibiotic use. So antibiotics can disrupt the bacterial flora of the mouth and will make it more at risk for colonization by fungi. It's typically treated with antifungals like a nystatin rinse, and then usually recommend improved oral hygiene and then treatment of the underlying systemic disease that would be causing immunocompromise if possible. All right, this is hairy leukoplakia. This is a little bit more difficult to distinguish from dysplastic oral disease. So it is a white plaque with small projections. And even though it is a leukoplakia, this is caused by Epstein-Barr virus, typically found in immunocompromised populations. It was actually originally discovered in 1984 during the AIDS crisis. And they were having these AIDS patients come in, and they'd have these leukoplakia on the tongue or mainly the tongue. And they would determine that it actually is a result of Epstein-Barr virus. And especially with the advent of effective treatment for AIDS, if you treat the AIDS or the cause of immunosuppression, the Epstein-Barr virus will also be taken care of, and the hairy leukoplakia will resolve, which is something that is not found in the pre-malignant leukoplakias because there's nothing leukoplakia that is pre-malignant due to cellular changes will not. It has undergone irreversible changes and will not resolve. So antivirals, possibly retinoic acid, and treating the cause of immunosuppression will fix this and it'll go away. So there's no need to excise or otherwise surgically treat this disease. Another thing, this can also look frictional hyperkeratosis. It's also a white plaque. This can look a lot like cancer, but it is not a precancerous change. It is hyperkeratosis in response to friction, commonly caused by lip biting, cheek biting, dental restorations, or chewing tobacco. And this is why it's also especially tricky, is because you'll get a patient in that says they, go through a can of dip every day, and they put it right here in their one spot. And, you go to do the exam, and there is a white plaque there. And so it can be very difficult to tell, is that a kind of homogeneous leukoplakia that is pre-malignant, or is it hyperkeratosis? For most of us, it's going to take a biopsy to make that determination. I will say, working in Dr. Carlson's clinic, a lot of times he could just walk up and he could, by examination, make it, he could look at a lesion like that and say, I'm pretty sure that's not cancer, no biopsy needed. But if you're not a cancer specialist that has seen thousands of cancer patients, it's probably going to require a biopsy. In contrast, another form of kind of frictional hyperkeratosis is the linea alba. That translates to white line, and it is a hyperkeratosis in response to occlusal trauma, and the line is right along the occlusal plane. And it is a very distinctive appearance, and this does not need biopsy just because of the extremely low probability that it is malignant and almost certainly hyperkeratosis in response to trauma. Nicotinic stomatitis. It's also called smoker's palate. It's a white plaque. Looks a lot like dysplasia or cancer. It is hyperkeratosis caused by toxins and heat from smoking, and most commonly seen in reverse smoking, which most Americans probably aren't familiar with that, but in some cultures, particularly in Asia, it's where you put the lit end of the cigarette in your mouth and smoke. And that's why I have that photo below of a gentleman in Singapore, and this guy is reverse smoking. And I can't tell you exactly what the reason is. Some people like to do that, but yeah, especially in South Asia and places like that, it is not uncommon. This nicotinic stomatitis, much less common in conventional smokers, but it can happen. And just because reverse smoking is uncommon in the United States, if you see this, it will be most likely in a conventional smoker. Lichen planus. This can also look pretty scary, particularly if it's like got some white patches there mixed with red areas. This can look like oral cancer. However, it's not dysplastic. It is a T-cell mediated chronic autoimmune disease. And you can see kind of white patches and lacy threads known as Wickham striae. And those lacy threads are really seen there on that lower lip in the lower picture. And it's treated with steroids. But unlike a lot of these, there is a malignant transformation rate somewhere less than 1%. In the erosive variant, it's kind of seen with the red areas in that top picture. They can be as high as 5%. White sponge nevus. Also, when you look at it, looks a lot like dysplasia or oral cancer. It's a thickened white spongy plaque. However, it is a rare benign hereditary condition that is generally inherited in an autosomal dominant pattern and caused by mutations in genes that code for keratin proteins. So I would expect most people would probably need to biopsy this to firmly conclude that it is a benign lesion, but you can ask about family history if you see like kind of this thickened white spongy plaque that doesn't quite look like a normal leukoplakia, and if they say, well, my dad had it and his dad had it, and they never got cancer, that might raise your clinical suspicion that this is white sponge nevus and it's hereditary and benign. And this is leukodema. Another condition that also is kind of whitish and is more common in smokers. So if you have a person that comes in and tells you they've smoked 2 packs a day for 30 years and they've got this whiteness to their cheek, that can make you kind of concerned that, what is this? Is this potentially like a dysplastic or cancerous condition? However, kind of the milky white or grayish white opalescence has a pretty distinct appearance. People that see lots of leukoplakia can distinguish this. If you don't commonly see a lot of leukoplakia, it may be very difficult. But it's intracellular edema of the epithelial cells and retained perikeratin. It is benign with no known transformation rate. But yeah, don't feel bad if you have to biopsy this to make the determination. All right, so now I've mentioned biopsy for a couple of these, and so let's talk a little bit about when to biopsy. So most guidelines say any suspicion lesion that cannot be wiped off and so therefore is not candida and has been present in the mouth for more than 2 to 4 weeks. I usually go by 3 weeks is my standard. And so if somebody comes in and said like, oh yeah, I'm pretty sure this is new, it's been there a week, I'll just see them back in 2 or 3 weeks, and if it's still there, I'll biopsy. If somebody's very wishy-washy about how long it's been there, if they say, I don't know, like, I noticed it, a couple weeks ago, but it might have been there a long time, I would go ahead and just biopsy that. Um, a scalpel or a punch biopsy are both acceptable. So you can see a 15 blade there in the top picture, or a like a 5 mm punch down there on the bottom. A couple tips when doing this. I'd recommend avoiding injecting local anesthesia directly into the lesion. This is because it's going to disrupt the cellular architecture that the pathologist is looking at when they're trying to read this. So it's just going to make the whole picture more confusing. So I just really try to inject deep or try a block to make this tolerable to the patient, but don't just direct pump a bunch of local straight into it. Also, there, for some reason, in a lot of dental schools, and mine included, they told us that we needed to biopsy the edge of the lesion so the pathologist could see the transition from normal tissue to abnormal tissue. And that is just not true. It's fake news. I don't know how that got started. A lot of people wish that dental schools would stop saying this, but really you just need to sample the most abnormal looking part of the lesion while avoiding necrotic tissue. So a lot of these, if it's an ulcerated lesion, it can have a center that just has a bunch of like obviously dead or purulent substance. And if you biopsy that, the pathologist is only going to see a bunch of dead cells and they can't determine much of anything from that. So you do need to biopsy living tissue, but just try to biopsy the most abnormal looking living tissue. And then finally, do not remove in its entirety unless you're a person that treats cancer, because occasionally in a clinic that does deal with cancer, you'll get patients that have undergone biopsies that turned out to be positive for cancer, but the biopsy entirely removed all of the abnormal tissue, so there's no way to know where it actually was. And so that makes it impossible to go back in and take a safe margin, meaning like with cancer, you need to take a bit of normal tissue to make sure there's no microinvasive cancer cells that put you at risk of spread after surgery. So if you're doing a biopsy, do not remove the entirety of the lesion, so that once you do, so if you do need to send it to a cancer specialist, the cancer specialist can tell exactly where the lesion is. All right. Wanted to just touch on histology a little bit. I don't want to go through all this. This is a lot of detail, but I think it's helpful as a clinician to be aware that this is how pathologists think about determining dysplasia versus cancer. When they get a tissue sample, they take a look at it and they score it based on agreed upon criteria. They look at the cells, they look to see how many of them are undergoing division, how thick, how many and thick these layers of possibly abnormal cells are, and how much of the epithelium is involved. Is it just the top third, or is it all the way through down to the basement membrane? And once it gets all the way from top down to the basement membrane, that's carcinoma in situ. And then once the dysplasia breaks through the basement membrane and spreads beyond that, that is when it's that's when it's termed a cancer. And so from the AAOMS position paper on management of dysplasia, here's the algorithm. Bottom line, with mild dysplasia, in many cases it can be merely observed. You do need to see these patients, or somebody needs to be seeing these patients at regular follow-up, whether that's once every 6 months or annually. They need it, and they will need it for the rest of their lives. And or if patient has severe dysplasia or carcinoma in situ, that's always an excision. And then long-term follow-up. And then for the in-between cases, so if they've got mild dysplasia and they have a lot of high-risk factors, or they're somewhere in between, that kind of comes down to the clinician's judgment, and really probably should be a judgment made by a head and neck cancer specialist.
Dr. Scott, I hate to interrupt you, but we have like 5 minutes left for this.
Yes.
Did you have any other slides that you'd like to share that?
Oh yeah, we got about 2 minutes left.
Okay.
Yep. So going on, here's TNM staging. Like all cancers, it's staged using a TNM system based on tumor size and then presence of nodes and where those nodes are. We don't really need to go over this in detail, but for the tumor size, it's all based on if it's less than 2 centimeters, or if it's from 2 to 4 or greater than 4. And then nodes, those are the criteria for nodal diagnosis. And then M for metastases, it's either 0 or 1. M0 is no mets, IB1 is a distant metastasis. And this feeds into the algorithm, which I'm not going to go into detail, but this is the detailed algorithm employed by MD Anderson, and is pretty similar to how I trained in managing head and neck cancer. So it all is determined by the TNM stage. And to simplify this, this is basically, I think of it in terms of, because I'm a skier, green circle, red square, black diamond, or double black. So if it's green circle, if it's a relatively mild cancer, small tumor with no nodes, you just take out the tumor, maybe do a neck section, and then if there's any adverse features, you can consider chemo or it'll need radiation plus or minus chemo. If it is a really bad tumor, if it's resectable, you resect it and then proceed straight to radiation, possible chemo. And then if it's unresectable, you try chemo radiation first, possible clinical trial, and then potentially if it shrinks down, you can consider surgery. But this is all stuff that's going to be done by the cancer specialist and planned out, usually using a tumor board, which is a collection of cancer specialists to include radiation oncology, medical oncology, and a surgeon to plan these patients out in a interdisciplinary fashion. And that's really the talk I wanted to give, and I'm happy to take any questions.
Thank you, Dr. Scott, for that amazing information. And we do have a few questions in our question and answer box. The first question was, is the 300 times risk specific to head and neck cancer incidence or cancer incidence in general?
That is oral cancer specifically. Does that answer that, or?
I'm not sure.
Okay.
That was posted by one of our attendees.
But yeah, that
And
is.
then our other question was, who can offer oral cancer screening? My dentist or PCP? Is this covered by insurance?
That I would say every dentist, I would expect, needs to be able to do an oral cancer screening. It is a standard of care, and every dental school trains in it. I think it's a little bit more variable within the medical curriculum. Having been through medical school, I can tell you that not a lot of training specific to oral cancer screening. And so it kind of comes down to whether or not that family practice residency or internal medicine residency trains those residents to do an oral cancer exam. And a lot of medical doctors really are very hesitant to look in the mouth. And so I think overall, most likely by a dentist is probably your best bet. And overall is it's going to be covered by insurance and should be really incorporated to every initial exam a dentist provides.
Thank you for that. And then another question. For someone who doesn't use tobacco products but drinks alcohol socially, how often should they receive oral cancer screenings?
Let's see, I'd say probably at least I mean, hopefully you're going to your dentist every 6 months. And yeah, so it should be every time you go there. Yeah.
And then does research exploring combined risk of oral cancer from having HPV and using marijuana look at only those with active infections, or does it also include those who no longer have abnormal paths or have dormant cases?
Right. So typically the high risk cases are, or the high risk variants of the HPV are ones in which it is a chronic infection that is typically asymptomatic. So usually the ones like the HPV 6 and 11 are the ones that are really the ones that cause warts and are going to be, so they're more symptomatic, like they're there because you've got a little papilla, but they are not carcinogenic. But the high risk variants typically you have no idea you have it, and they are chronic infections. And so, I mean, a lot of the way they do these studies is they once the pathology is analyzed, they stain it for HPV, and so they have to make the determination of HPV status typically after biopsy.
Thank you for that, Dr. Scott. I believe we have all our questions. Thank you again, everyone, for coming and joining us for our webinar today. I will be sending anyone that's attended today, I'll be sending a link to the video for this webinar. And then, oops, let me push.